So good afternoon, students. So in the efforts of the ISFCP regarding the improvement of the teaching learning process, we welcome again you to the online video lecture series of B Farm 6th semester in the subject biopharmaceutics and the pharmacokinetics. So myself, Dr. Dilpreet Singh, working as an associate professor in the pharmaceutics department and your subject teacher in biopharmaceutics and the pharmacokinetics. So in the previous lecture, we have discussed about the factor affecting the drug absorption in the category that is biopharmaceutical factors and the physicochemical factors. So in continuation with the lecture, we have now discussed about the patient-related factors that affecting the drug absorption. So the patient-related factors which are summarized below. In the patient-related factors, first of all, we have discussed about the age. So in the medical field, the age is divided into two, that is basically infants and the elderly. In infants, the gastric pH is quite high, and the intestinal surface, which lining the blood flow to the GIT, is very low, which causes the altered absorption pattern as compared to the adults. So, but in the elderly patient, gastric emptying is very altered. It causes the zigzag motion and which causes the decreased intestinal surface area and GI blood flow. So there is a high chances of the patient that will suffer from a carbohydrate that is reducing gastric content. So it also impairs the drug absorption because some of the drug is basically pH dependent soluble. So that pH dependent solubility is causes the gastric emptying and it causes the patient to be suffered from more chlorhydria, and the unionized content of the drug leads to greater excretion and less chances of the drug will go into the blood. So so hence there causes the unpaired drug absorption as compared to the adults and in case of the infants. So the gastric emptying time, the process by which the food leaves the stomach and is enters the duodenum. So rapid gastric emptying is required when the drug is best absorbed from the distal part of the small intestine. So gastric emptying time is one of the most important parameter when we study the drug in the food and the faster state. In the fat state, there could be the chances that the endophospholipid will help to absorb the drug and enters the duodenum. But in the faster state, the gastric emptying play an important role in the drug absorption from the distal part of the intestine. So when we talk about the distal part of the intestine, the food leaves the stomach and it causes the impaired absorption as compared to fat state. So as I already discussed with you that delayed gastric emptying is required when drugs are absorbed from the proximal part of the small intestine, and prolonged drug absorption is required when we need a sustained release or we need a delayed type of the formulation. So it is also dependent upon the which type of the formulation is we want to design for delayed gastric emptying or for the optimal absorption. So gastric emptying is basically a first order process. It is basically independent of the rate and is independent of the concentration. So gastric emptying, this is the speed at which the stomach content empty into the intestine. So basically, it is the time required for the gastric content to the small intestine. Basically, is the flowable. It is the transfer ratio or is the transfer time that basically the all the contents of the gastrointestinal tract basically between the transfer from the internal to the external environment, that is basically called as gastric emptying time. So basically, when we talk about the acidic drug, the gastric emptying time play a major role because stomach is the one of the most important absorption window when we talk about the absorption of the acidic drug, because acidic drug is partially ionized at basic pH and the partially ionized drugs it shows the reabsorption at the kidney. So proper reabsorption is there. So there is need of the absorption carrier transport. So if the stomach is under gastric emptying, the reabsorption is very quick and which leads to the improvement in the bioavailability and the therapeutic effect. When we talk about the basic drugs carry the molecule outside the duodenum. So there is a chances that it should be like the delayed gastric emptying as compared to the normal gastric emptying time. So there is a chart. It depicts the which type of the meal we have taken to improve the gastric emptying take. So type of the meal it greatly impart the gastric emptying take. For example, carbohydrates. So carbohydrate it show better gastric emptying rate as compared to protein as compared to fat. So the physical state of the gastric contents like the solution or the suspension of the small particles which travel more rapidly than chunks of the material that should be reduced particle size in prior to emptying. So less particle size, it moves towards the faster rate into the duodenum as compared to the macro size particles. So the body position it also depicts the gastric emptying time. So lying on the left side, it decreases the emptying rate as compared to the right side, which promotes it. So drugs that creates a major effect. For example, basic drug that I have already discussed with you, that anticholinergics, narcotic analgesics, ethanol, or some of the macrolide antibiotics, they help in the reduction of the gastric emptying because acidic content in the stomach will absorb under this drug. So drug enzyme interaction that can play a major role in the reduction in the gastric emptying. However, the acidic drugs like we have the NSAIDs, phenytoin, deltiazem, phenylazine, or metoclopramide, they can help in the improvement of gastric content because gastric content adhere in the wall under the influence of the enzyme induction. So basic drug will help to induce the enzyme property which creates drugs to be metabolized under certain conditions. So if the drug is basic in nature, the enzyme in the liver it creates the induction effect to the drug which will lead to the adherence of the gastric content and it leads to the improvement in the gastric emptying rate. So in the emotional state, if the we call as the normal psychological state, then gastric emptying is much better. When we call as the person is suffering from the anxiety disorder or a panic attack or short-term anxiety disorder, or we call as the person is suffering from the anxiety or what we call as the gastric ulcer, hypothyroidism, like the diseases which creates a zigzag motion in the enzyme content, it will retards the gastric emptying rate. Wherever the inflammation condition like duodenal ulcer, like we have the gastritis, like we have the polynephritis, it promotes the gastric emptying. So in the intestinal transit time, this is one of the major site of the absorption of the most of the drug. The mixing movement of the intestine that primarily been occur due to the peristaltic contraction. These peristaltic contraction that it promotes the drug absorption by increasing the drug intestinal membrane contact and the basolateral to lateral side of the apical membrane. So the movement of the drug from the basolateral to apical membrane under the some concentration gradient or the electrochemical gradient generated, it promotes the intestinal transit time. Secondly, by enhancing the drug dissolution of the poorly soluble drugs, it induces the agitation. So, induced agitation will lead to the improvement in the intestinal transit time. So, delayed intestinal transit it is desirable for the drugs that dissolve or release slowly from their dosage form. For example, like the sustained release product. So, drug that will dissolve only in the intestine, that is example of the enteric formulation. So drug that will absorb from the site specific sites in the intestine that will causes like the vitamin B12. So several lipophilic vitamin B12 is absorbed from the specific site in the intestine that causes the intestinal transit time. So intestinal transit time that can play a major role in different formulations also. The strength of the dosage form, the type of the dosage form. So it show variable absorption rate depending upon the which type of the dosage form you have considered or which of the dosage forms you have taken in which route. For example, when we talk about the IV route, then intestinal transit time doesn't play any major role because IV formulation directly goes into the blood. So they have less chances of metabolism, less chances of the absorption is there because it goes directly into systemic circulation for therapeutic drug. When we talk about the drug given topically or oral formulation, then drug absorbed from the specific sites in the intestine, like the duodenum, like we have the intestinal epithelium. So certain transporters, they are like ABC binding acid transporters, P glycoprotein that can also help in the delaying the intestinal transit time, which promote the absorption of the several vitamin B12 hormones. Then we have the uh, some lipophilic drugs, some hydrophilic molecule is there. So it depends on the type to type formulation, which promotes or delay the intestinal transit time. So in the intestinal transit time, in the different regions, they are summarized below. Duodenum, it show a transit time of 5 minutes. In jejunum, because jejunum it containing the number of the ABC binding cassette transporters, or it containing the number of protein expression is there. So it creates a longer transit time of about 2 hours. Ileum, it containing the most of the enzymes that causes digestion, or most of the microbiota like our bacteria which promote the absorption of many food junks or many lipid molecules. So it creates a greater transit time of about 3 to 6 hours. Cecum or column, it show a transit time of zero point 0.1 to 1 hour, or it show a transit time of 6 to 12 hours respectively. So intestinal transit time is influenced by the various factors such as food, diseases, or drug. But when we talk about the food, so lipid-rich diet, which containing the saturation, it improves the intestinal transit time. When we talk about the diseases, the inflammation condition like the polynephritis, gingivitis, or what we call as the gastritis, it leads to decrease in intestinal content because the surface area is very very slow due to the inflammation in the lining of the tissue. So it creates a delay in the gastric emptying. So some drugs, they like the enzyme inducer or enzyme inhibitor, they can create a major effect in the intestinal transit time. Some enzyme inducers, like we have the metoclopramide, like we have the antibiotics used in the bacterial infection in the stomach, that can also improve the intestinal transit time due to the inhibition of certain transporter in the intestine. Example, metoclopramide, I have already given you the example. It promotes the intestinal transit, and it leads to the non-absorption of the rapidly water-soluble drugs, while anticholinergic drugs, because anticholinergic drugs having that substrate that is cholinesterase, inhibition of that enzyme, it retards the intestinal transit, and it promotes the absorption of the various poorly soluble drug molecules. So when we talk about the depiction of the gastrointestinal content, so it show a different pH region. So when we talk about mouse, the pH is about 6.8. It having a small surface area, and it is eligible for the delivery of lipophilic, neutral, and basic drug that will absorb directly in the circulation. When we talk about the stomach, the pH is around 1 to 3, not too large surface area, but it should be ideal for the lipophilic or neutral molecules that will absorb, but it show lesser extent than small intestine. The drug basically absorb primarily to the small and the large intestine. Small intestine, it show the pH of 5 to 7.5. It having very large surface area for absorption. So about 90% of the drug it get absorbed, and it show a major site of drug absorption. When we talk about the larger intestine, the pH is around 7.9 to 8. So it show a smaller surface area. So the drug which having the molecular weight less than 500 daltons, it will absorb but to a lesser extent. Liver is the major site of the drug metabolism. We are already know that. Bile, it shows a pH of 7.8 to 8.6, and it aids in the absorption of the lipophilic drugs, which is primarily been active for polar molecules or drug metabolites. When we talk about the rectum, so rectum basically most of the suppositories which needs quick absorption, which needs a quick faster rate of therapeutic effects, it will deliver to a rectum route. It show a pH of 7.5 to 8. It show a very small surface area. So most of the drug which need quicker action that are absorbed, about half of the absorbed drug that goes directly into the systemic circulation. So when we talk about the disease state, gastric diseases like the that is basically the patient that suffers from the inadequate production of acid. That is basically called as achlorhydria in the stomach. So achlorhydria is essential for the solubilizing the insoluble free bases. So inadequate production of the acid creates the what we called as the partially ionized state of the drug. So partially ionized state that are not been reabsorbed and are excreted quickly. So lead to the decreased absorption of the drug. So many weakly basic drug that cannot form the salt, and it remain to be undissolved. So therefore it is categorized as an unabsorbed drug. So salt form of the drug cannot be prepared because जो free base that is basically readily be precipitated out. So the precipitated out molecule it show a unchanged form of excretion. So the concentration of the protein bind drug is very very less. So it show variable absorption as compared to fully ionized drug. For example, dapsone, itraconazole, or ketoconazole. When we talk about the cardiovascular diseases, so several changes was seen in the congestive heart failure patient due to the bioavailability of the drug. So most of the drugs which show a erratic viability, it show a linear or unlinear therapeutic effect in the cardiac patients. For example, like the edema of the intestine, it causes the decreased blood flow to the GIT and the gastric emptying rate. So altered GI pH and the edema of the intestine causes the poor secretions and the what we call as the uh, non-uniformity in the microbial flora. So non-uniformity in the microbial flora, it causes the more worsen to the congestive heart failure patient that show unlinear absorption profile as compared to normal diseases. This is one of the important factor. Blood is called blood flow through the GIT. So blood flow through the GIT, it plays a major role in the absorption by continuously maintaining the concentration gradient across the epithelial membrane. So I have already told you in the previous lecture when we talk about the absorption of the drug. So most of the absorption mechanism, it follows the concentration gradient. So concentration gradient is created by the hydrostatic pressure or the capillary pressure that lining in the RBC cells. So most of the transporter, most of the tight junctions, most of the ion channels, it creates a concentration gradient in the cells, which creates a solubilized state of the drug in the intestinal fluid, and it allows the absorption of the most of the drug from the upward concentration gradient from one side to the another. That is one side we the concentration at the site of administration. Another side is the concentration at the site of action. The GIT is extensively supplied by the blood capillary network. So blood flow is very important for the actively absorption of the many endogenous or many lipophilic drugs. So the absorption of the polar molecule doesn't depend upon the blood flow, but the lipid soluble molecule it highly depend upon the blood flow because lipid soluble molecule are unable to get solubilized state when we talk about the endophospholipid because our bile salt and endophospholipid they are hydrophilic in nature, so they getting been solubilized in the hydrophilic nature. So they entirely been dependent upon the blood flow through the GIT as compared to the absorption of the non-polar molecule. So what we call as the effect of the food on the blood flow. So food influences the blood flow to the GIT. So when we talk about the fed state, then perfusion it increased after the meals and it persists for about 2 to 3 hours. However, absorption is not affected when we talk about the perfusion because perfusion is independent of the absorption. So food it only influences the blood flow to the GIT. When we talk about the gastrointestinal content, so food drug interaction that play a major role when we talk about the therapy that is called the anti-tubercular therapy, anti-malarial therapy, or that diseases which needs a proper incubation and the treatment protocol. The presence of the food in the GIT that can affect the bioavailability of many drugs because the digestive food it containing lipids, it containing the amino acid, fatty acids, and many nutrients that can affect the intestinal pH, that may uniform the microbiota, and that may also improve the solubility of the drugs. So some of the effects on the food that on the viability of a drug product, including some mechanism like the delay in the gastric emptying. So food helps to provide delay in the gastric emptying. It will also help to improve the stimulation of the bile flow. It will also help to improve the pH of the GI tract and it also help to improve in the splenic blood flow. So improvement in the splenic blood flow leads to improvement in the absorption of the many poorly water soluble compounds. So the presence of food, it will affect the absorption in many ways. For example, decrease absorption. So decrease absorption like the penicillin, like the erythromycin, like the ethanol, like the tetracycline, levodopa, it will decrease the it will show decreased absorption in presence of food because presence of food it delay the gastric emptying when we talk about the delivery of these drugs. When we talk about the increased absorption, so like we have the vitamins, then we have the anti-epileptic drugs, antifungal drugs like racifulvin, anti-malarial drugs like chloroquine, anti-tubercular therapy, that is basically three-in-one therapy, that is isoniazid, rifampicin, and ethambutol, 21 days therapy that will it show greater absorption in the presence of food. When we talk about the fluid volume, so larger fluid volume, it results in the better dissolution. It shows rapid gastric emptying rate and it leads to enhanced absorption. For example, the erythromycin. So erythromycin is better absorbed when we taken with a glass of water because hydrophilic nature, hydrophilic content in the stomach or hydrophilicity, and we call the alkalinity in the body, it improves the absorption of the certain macrolide antibodies than when we take with the meals. So when we talk about the interaction of the drug with the normal GI constituents, so the GIT contains a number of normal constituents. One of the prime constituent is the mucin, which is a protective mucopolysaccharide that lining the GI mucosa. It interacts with certain anti-cancer compounds, certain anti-macrolide antibody, certain bacterial antibodies, which affect the absorption profile when we talk about the therapeutic effect, when we talk about to maintain the therapeutic window. So mucin they show some protective role. Mucin in some cases it show a disadvantageous role when we talk about the absorption of the drug. This is one of the most trending topic when we take on the drug orally, that is called pre-systemic metabolism. So number of the scientists it works with the pre-systemic metabolism because pre-systemic metabolism it causes the loss of the drug because pre-systemic metabolism it is also called as biotransformation. So biotransformation means conversion of a conventional molecule to no new molecule by introducing a new functional group by cleavage or by conjugation. The three mechanism is there. It always show the loss of the drug because when we talk about the hepatic metabolism, the cytochrome P450 mediators they are involved in the reducing the metabolism by generating the daughter metabolites which are almost excreted in the urine. So parent metabolite concentration is very less. So it shows the subtherapeutic levels in the absorption window. So the definition basically what is the pre-systemic metabolism? So the loss of the drug through biotransformation by such eliminating organ during the passage to the systemic circulation. It is called the first pass or pre-systemic metabolism. So complete absorption of the drug in the plasma after the oral administration is an indicative factor to the first pass effect and the hepatic effect. So the four primary systems which affect the pre-systemic metabolism like the luminal enzymes like the gut wall enzymes, like the mucosal enzymes, like we call as the hepatic or the bacterial enzyme that can play a major role in the pre-systemic or the hepatic metabolism. When we talk about the luminal enzyme, this is a primary enzyme that found in the gastric juice is pepsin. So pepsin it promotes the absorption of the many endogenous compounds. So lipases, amylases, and proteases basically which that are secreted from the pancreas into the small intestine, which is in the response to the ingestion of the food. So proteases and pepsin they are responsible for the degradation of the protein and the peptide drugs in the lumen. So gut wall enzymes basically that are called the mucosal enzymes. They are present in the stomach and the intestine and are responsible for the most of the basic drug that are basically absorbed through colon. So aldehyde dehydrogenase is the example of the gut wall enzyme which convert aldehyde into carboxylic acid because what we call as the alcohol is the inactive form when we taken orally. So it convert under the aldehyde dehydrogenase alcohol dehydrogenase it convert into inactivated form that is called carboxylic acid which promotes the absorption of the alcohol. So another example like this sulfation of the ethylene estradiol and the isoquinoline. Bacterial enzyme, which is basically located within the colonic region of the gastrointestinal tract, and it also helps to secrete various enzymes which are capable of producing the wider range of the metabolic and non-metabolic reaction. So metabolic reaction, it including the microsomal reaction or non-microsomal. Microsomal reaction, it including the what we call as the oxidation, reduction, and the hydrolysis, which convert a lipophilic moiety to a hydrophilic moiety which will show better absorption as compared to parent metabolite. For example, sulfasalazine. So sulfasalazine basically is a lipophilic moiety. So it is basically a pro-drug and it converts into 5-amino salicylic acid via a azo bond reduction to active metabolite that is called sulfapyridine. When we talk about the hepatic enzymes, so several drugs which undergo first pass metabolism, they are highly affected by the hepatic enzyme. So basically, this picture it shows that the when we taken the drug orally and drug it moves towards the gut into the portal vein. So in the portal vein there is first pass metabolism which held in the liver by certain enzyme that is called phase 2 enzyme. Phase 2 enzyme is basically called the cytochrome P450 enzyme that are responsible for the majority of the drug excreted unchanged in the urine. So majority of the drug excreted unchanged. So lesser chances is that there for the for the parent drug to be bound to the plasma protein, and it shows the drug in a subtherapeutic level when it goes into the systemic circulation. So in this present topic, the question that could be coming in your exams like that, what are the type of the drugs, whether the acidic, basic or neutral that will better absorb from the small intestine. So the answer is that it depends upon the what is the absorption mechanism. It depends upon the what is the physiology of the patient. It depends upon the what is the GI content. What is it? It is depend upon the age. So it is basically is not a hit and trial method. So which one is the better absorb? But when we select a one option, so I will suggest you to select a basic drug, because basic drug that are ionized properly and is properly absorbed as compared to the parent metabolite. Second question is that for which drug rapid gastric emptying is desirable and when should it be slow? So I will suggest you to select the acidic drug, because the acidic drug rapid gastric emptying is there, and it should be rapid gastric emptying is there, and it should be show better absorption as compared to the basic drugs. So third question is that discuss briefly about the factor affecting the gastrointestinal content of the drug. You have answered it. What are the possible reasons for the delayed or faster adoption of a drug after the meals? And why biopharmaceutical studies that are required the drug to be taken early and to be performed in the volunteers on the empty stomach? What are the consequences of various disease state on the oral bioavailability of a drug? I have already discussed about the cardiac feature. I have already discussed with you the overcalorhydria, and what is the other disease state on the oral bioavailability. What are the various mechanisms for drug-drug interaction in the GIT? What are the different sides of the pre-systemic metabolism of orally administered drugs? So this is the references that I have suggested you to refer these books for the better learning. That is Biomarker, which is basically for absorption, biopharmaceutics and the pharmacokinetics, and the international book that is Sharjal, that it linked with the physiological factor that relate to drug absorption. So thank you very much for your kind attention. So any suggestion you can discuss with me in the listed address. Thank you.